Inga mana, inga reo, ro rakatera ma, tēnā koutou, tēnā tato katoa. Ko Harleen Hain tako wingawa, ko te tumuaki o te whariwana ka oa tako aho. Nā mihi nui kia koutou, nō reira, tēnā koutou, tēnā tato katoa. Good evening, everyone. My name is Harleen Hain, and I have the great privilege of being the Vice Chancellor here at the University of Otago. And it gives me great pleasure to be the first person to welcome you to this inaugural professorial lecture for Rhiannon Braund. On behalf of the university, I would like to begin by extending a particularly warm welcome to members of Rhiannon's family who are here today. Her husband, Harry, her children, Cam and Ash, and her mum, Marilyn, who have joined us. You are very, very welcome to be here. Ngā mihi nui kia koutou. I'd also like to acknowledge all of the staff and students from across the university, and as I look out on the audience, I can see people from all 4 of our academic divisions, and it's fantastic to have you here joining us in the celebration of Rhiannon's success. And in addition to folks from the university, I also note members of our wider Dunedin community who often use these lectures as an opportunity for their own ongoing learning and development. And as always, you are very, very welcome to be here. And last but not least, I would like to give a very warm welcome to our Chancellor, Dr. Royden Somerville, who religiously takes time out of his very busy day to join us for these very special occasions. Now, these inaugural professorial lectures are a time of immense celebration for the University of Otago, and I am absolutely delighted to see so many people here. We should all take a moment and reflect on the fact that these kinds of lectures are actually rare around the world right now, and it's wonderful that we can all come together for a time of fellowship and learning around the celebration of Rhiannon's success. Now, after everything that we've been through this year, it is fantastic for us to have the opportunity to come together. And tonight is particularly special for me because today actually marks my 9th year anniversary of being the Vice Chancellor here at the University of Otago. So thank you, Rhiannon, for throwing this very large party. Now, as you will learn from Rhiannon's lecture this evening, she is an award-winning teacher, a popular postgraduate supervisor, and a highly successful researcher. She has also provided exceptional and selfless service to her discipline, to her school, to the university, and to her profession. Rhiannon, on behalf of the university, it gives me great pleasure to congratulate you on your very, very well-earned promotion to professor. I am very much looking forward to your lecture this evening. I will now call on the head of department of the Department of Preventive and Social Medicine, Associate Professor Patricia Priest, who is going to tell us just a little bit more about Rhiannon's journey to professor. Nō reira, tēnā koutou, tēnā tato katoa.
Tēnā koutou. I'm privileged to introduce Professor Rhiannon Braund, and I'm going to say Professor Braund quite often because it's so exciting. Rhiannon Braund commenced her University of Otago experience with a degree in biochemistry, moving on to a second degree in pharmacy and qualifying as a registered pharmacist in 2003. She was a practicing pharmacist for a few years before commencing in a lecturing position at the University of Otago at the School of Pharmacy. She rose through the academic ranks to become an associate professor in clinical pharmacy in 2014. 2 years ago, we were delighted to welcome her to the Department of Preventive and Social Medicine when she took up a position in the New Zealand Pharmacovigilance Centre. Professor Braund's talk is called Medications in Aotearoa New Zealand, Access, Excess and Outcomes, which nicely summarises the breadth of her research. Her work has a strong focus on equity, includes consideration of patient behaviours regarding adherence and medication wastage. For those of you not from the university, I want to just re-mention what Professor Hain said, which is that promotion to professor is based on competence across the 3 components of academic work, not just research, but also teaching and what we call service. Professor Braund is a highly successful teacher, and her passion for pharmacy and student success was recognised in 2012 when she was awarded the Prime Minister's Award for Tertiary Teaching Excellence. In terms of service, Professor Braund's expertise has been recognised across many areas. Her research into advanced roles for pharmacists and support staff has resulted in multiple practice changes and new models of care, both locally and internationally. Her professional recognitions include fellowships of both New Zealand College and the Pharmaceutical Society of New Zealand, and she holds national leadership roles to enhance the use of medications and improve patient access and outcomes through better utilisation of pharmacists. The talk we're about to hear will include discussion about how policies on access to medicines in New Zealand, along with patient behaviour, can lead to excess medication stockpiles and medication wastage, and the many outcomes of that wastage, including financial, clinical and environmental. In finishing her lecture, Professor Braund will bring it all together by emphasising the relationship between research and teaching and how the authenticity of research-informed teaching can advance professional practice. I know that Professor Braund has chosen to highlight work that makes her proud rather than necessarily just that has the so-called metrics of success, and that much of this work is in collaboration with others. Making the world a better place truly requires good collaboration, and I want to congratulate Professor Braund on her achievements in working with others, as well as personally meeting the criteria for Professor. I'm proud now to hand over to Professor Rhiannon Braund to deliver her inaugural professorial lecture.
Hello, thank you so much for taking the time and coming to this talk of mine tonight. I really want to start off by saying that actually this lecture today is really, while it's a professional, personal milestone for me, it's really an opportunity for me to thank the people that I've worked with me, and some of the contributions that we've made in the way that medicines are used and accessed within New Zealand. During this presentation, I particularly want to recognise and acknowledge those who've walked with me on this journey, and those who continue to challenge, to inspire and motivate me to make a difference to people's wellness. As was mentioned earlier, I've decided to focus on a few projects that really make me proud. These are the ones that I feel contributed in far-reaching ways. I wanted to start off with a favourite sort of saying of mine, he a te mea nueo te ao. He tangata, he tangata, he tangata. What is the most important thing in the world? It is people, it is people, it is people. This is one of the things that I really have strived to remember, to hold on to in the research journey that I've been on. The things that we do, the way that we conduct ourselves, the way that we choose to integrate and interact with the world, people should always remain at the centre of what we do. I thought that I would talk a little bit about the way medicines are accessed in New Zealand. We'll definitely talk about access, and we'll definitely talk about outcomes today. And I'm aware in this audience we've got a diverse range of knowledge of this area, so I really wanted to step back and set the scene. There was a strong policy document that came out from the Ministry of Health, and it was Implementing Medicines New Zealand. And one of the key messages through this was that medicines remain the most common health interventions, and this is irrespective of clinical area. As a pharmacist, I'm a very proud pharmacist. We know that pharmacists have particular skills and their expertise, medicines experts. Okay? Doesn't mean that we are necessarily the most amazing clinicians, it's not our job, but we do know a lot about medicines. We know when to use them and when not to use them, and how to use them safely and effectively. The other thing that comes with being a pharmacist is our location and our place in the health system. Pharmacists continue to be one of the most accessible health professionals, mainly for several reasons, including the fact that there's no need for scheduling, there's lower cost when you come and see a pharmacist, you can get advice for free. We also tend to have more locations, and we tend to be open longer hours. And so we continue to play a really key role in primary care. But I do want to just talk about medicines as having the potential for harm. So we think about medicines as being, safe, and most of the time they are, but they do have the potential for harm. So we need to use a little bit of caution when we choose to use medicines. One of the areas that I'm going to talk about in this lecture is reclassification, and that's a way of increasing access. So I thought I'd just walk us through how classification of medicines works in New Zealand. So we have different levels of classification, which are based on the access that is required and balanced against the safety needs, where medicines that maybe are potentially more dangerous might need a little bit more closer monitoring. Many of you will be familiar with paracetamol being a general sale medicine. This medicine can be bought from many locations, the warehouse, the dairy, the supermarket, okay? Where they put the safety constraints is around smaller pack sizes. Pharmacy only is the next level of care, or the next parameter, I guess, the next layer out about how we access medicines. And so pharmacy only are medicines that you can buy at a pharmacy, you can be sold to you by the front of shop staff, but again, there are restrictions about what these medicines are. And so paracetamol again sits in there, but this is when you start looking at your larger pack sizes. Liquid paracetamol is pharmacy only, so we have another layer of care in there. Not all countries around the world have this classification, which is pharmacist only. So these are medicines that can be sold by a pharmacist. Currently, one of the examples I've got on here is paracetamol and low-dose codeine. That's about to change, but there are medicines that are in that range of pharmacist-only medicines. One of the things that was introduced in New Zealand, and I will talk about a pioneer colleague, friend of mine, Dr. Natalie Gould, and we have the idea of having these particular medicines that can only be supplied by a qualified or accredited pharmacist. One of the nice examples in there is the emergency contraceptive pill. So you can get that from a pharmacy, and the reason that that's important is that if you need to access that outside of normal general practice hours, then you can go to your pharmacy. It's convenient for the patients. But only accredited pharmacists can supply this. So not every pharmacist, you have to have gone through specific training to make sure that you're competent, well-versed, and can have those kind of consultations. Most of you will be familiar with prescription-only medicines, so they come from prescriber. And again, we've got another layer of control, which is around our controlled drugs. I will talk a little bit about pharmac, and I think sometimes New Zealanders don't really appreciate how helpful, vital, crucial pharmac is for our medicines access in New Zealand. We have a pharmac, which is a government agency, and they are the drug purchasing agency. So they buy the medicines. And the way that we get the best deals, because we only have a finite bucket of money, is through negotiating in tenders. And one of the other mechanisms they use is what's called sole supply. Sole supply means that they pick one brand, and that brand has the exclusive access through New Zealand. In New Zealand, we generally have prescriptions that are written for 3 months. There are some exceptions, such as the oral contraceptive pill. And pharmac manages the way this is controlled. They write their scripts for 3 months. But there can be smaller amounts in certain criteria. In New Zealand, we have what's called a fully funded medicine. And this is really important for us to understand what that means. It doesn't mean that it's free. And this is one of the things that's really important in the New Zealand context, is actually nothing in healthcare is free. Everything has a cost, but it's about where that cost sits. So when a medicine is fully funded by pharmac, it doesn't mean it's free. It means that the government is paying a proportion, or the largest proportion of that cost usually, and there's a part charge, which is a tax, and that's where the patient pays $5. There are, again, some exceptions to that. One of the things that sometimes gets overlooked is that when a family reaches 20 items, that tax is removed, and then they become free to the person for that family for the rest of the year. This is incredibly affordable compared to many other countries in the world. It doesn't always feel affordable, but it is comparatively. And so this is important because one of the things that we spend a lot of time looking at, I'll skip through that, it's a scheduling one, is about how we increase access without leading to these sort of images, medicines wastage and medicines excess. And what we found in a lot of the work we did, so in 2003, pharmac introduced stat dispensing, or all-at-once dispensing. So patients got 3 months of their medicines all at once. What happened though is that in that first couple of weeks of a new medicine, where there's dose titrations or side effects, people then changed medicines. And so we had 2 months or 2.5 months of medicines left over. And this was quite concerning, definitely for me. When we think about access, we think about people that can't afford to get their medicines for themselves or their families, and then we start seeing buckets of medicines coming back. We realise that there's something in the system that it's not balancing out. And we've seen some of the volumes that come back home and that are then destroyed, and we'll talk a little bit about the ecological consequences soon. This was a result of one of the studies which looked at why people had medicines that hadn't been used. Past expiry date, the treatment's changed, the condition resolved. And so there's a whole lot of different reasons why medicines get left over. But one of the things that's really important to think about is people. Came back to this people. And when we understand patient behaviour and understand why these medicines get left over, we can start to think about a system that maybe promotes equity and equivalent access across different areas. So these two bright shining faces, hopefully some of you know, Professor Pauline Norris and Dr. James Green. And we've spent a lot of time thinking about the patient. So we think about the medicine as being accessible, it's here, it's this product, but why don't people use it? Why do we have leftover? Why do we have wastage? Pauline, by background, is a sociologist, and she's an incredibly talented researcher, particularly in the access space. James Green is a health psychologist, so psychologist by background. And so it's really nice working with non-pharmacists because they bring that much bigger perspective. So we started to look a little bit about health access. So why do people, or how do people access the system? We talked about the pharmac model, and that's really important because that's where the money sits. But actually, access isn't just about money. And we'll talk a little bit further on about some of pharmac's policies around increasing access to equity, because money is only one part of the problem. People are human. We make choices, we make decisions, and all of us have health beliefs. And so those will influence the way that these medicines are used. So a doctor might prescribe, a patient might collect the medicines, and then they might not take them depending on these health beliefs. So those things all matter. Health literacy is really important, and for those in the audience that have gone to university and trained in this, we sometimes forget that actually things that we think are obvious are really not that obvious. And you know, I remember talking to the students a couple of years ago about asthma inhalers, and every year there's a huge number of people that choke on their asthma inhaler because no one's ever told them to take the cap off. So they're puffing away on these inhalers, and things that we think, you know, are logical aren't always obvious when you come from a different worldview. And understanding adherence, so why people take medicines, why we don't take medicines, why we forget. You know, we all have busy schedules, busy lives, so we don't always take our medicines the way that they were intended. I just want to pause just really quickly here because there's a phrase that is really important to me. Medications only work in those who take them. And it's quite interesting. I did, as Patricia said, I started off in the biochemistry world, and I came to pharmacy because I was convinced that I was going to create these amazing molecules. I knew all about protein structures. I was going to do medchem. I was going to have all these amazing new creations. And I fell into pharmacy and realised that actually it doesn't really matter which of these amazing formulations you have, and there are some amazing formulation scientists that I know personally. If the patient doesn't take them, then they're actually worthless anyway. And so it's understanding those two things together, that clinical appropriateness, the drug entity, the formulation, and then actually understanding people is where the real value comes in. I mentioned two of the lovely people that I worked with. So these are another two, Professor Steve Duffel and our PhD student Jill. And this was taking a different approach at that same sort of idea. So where the work with Pauline and James had really thought about an individual, this work was about populations. And this is an incredibly complex diagram. But one of the things, what I'll go through relatively slowly. So on the vertical axis, it's about your percentage adherence. So how many times you actually take the medicine when you're supposed to. Across that sort of slanting down one is your age and bands of 20 years. And then to add to complexity is a dosing regime. So what this graph shows us is that if you're a 20-year-old and if you have a dosing schedule of 1 tablet a day, you're likely to only get 20% adherence, okay? And that if you're over 60 on a 1 dose a day, you're much closer to 100%. What's interesting again is that the more doses you have to take per day, the worse you are. Okay, so relatively, common sense. The more you have to remember, the more times you have to do it, the less likely it is that you will. This was really interesting, this work, because a lot of our adherence services, a lot of our support for medicines are geared around that older age group. And actually, most of them are really well under control. And the reason they're under control is that it's a beautiful piece of work that I think Pauline and June Tordoff did, which was saying that it's routine. They have a routine, it's with their cup of tea. They have blister packs, and actually a lot of them are quite well supported in that space. And where we really need to think about the way we support good medicines use is really in that middle bracket around those people that have got these busy lives, that have got other commitments where actually it's not such a priority. So that was quite a cool piece of work that we did. One of the other aspects of that work is about forgiving drugs. So these are drugs that if you're actually not as good as you're supposed to be, the drugs don't mind. So they'll still work as well. So one of the least forgiving drugs is the oral contraceptive pill. You miss that by a matter of hours and you could be in trouble. Whereas aspirin, you can actually take aspirin once a week because of the way that it works. So the idea is thinking, if we know that patients aren't going to do everything perfectly all the time, can we think about a drug that basically gives a bit of latitude? And so we've done some really cool stuff in that space. Again, one of the things I wanted to highlight is about the impacts on outcomes. And again, I know it's a busy graph and I'll walk you through it. We did some work with the Bay up at the Bay of Plenty and looking at diabetic medicines. And what this graph is saying is that, so HbA1c is a marker of how well controlled your diabetes is by looking at the amount of glucose that's attached to your blood cells. So where this patient's had a score, so an MUR score is a specific service that's provided by pharmacists, where they had a score of 1 or 2, their control, so 1 or 2 is not very good control, not very good adherence, their blood sugars kept getting worse over time. Whereas when they got to 3 and 4, you can see that their blood sugars became better controlled. And what this sort of says to us is that you don't have to be perfect. So 3 was okay, you didn't have to be perfect, but you can't be in that range where you're starting to skip doses. And this has real impact on patient outcomes, health outcomes. When we did a lot of the work around medicines wastage, we were quite concerned about antibiotics. And the reasons for that, if you think about what we've talked about already, patients, if they don't take their antibiotics regularly, then they can develop resistance. Then we have wasted antibiotics, which have got to go somewhere in the system. Again, it's another busy slide, which I've pinched from somewhere else. But really, this is quite interesting because the concept of One Health and the fact that antibiotics that we use in the vet sector has implications in the ecology sector, there's a whole lot of interplay around antibiotics. And I think this is really important for us as far as sustainability, as far as the environment, that everything we do goes somewhere. And it's quite interesting. Spent a lot of time working with the DEAR program with the police, and the kids at school. So we went on school visits and talked to them about how to use medicines. The kids at school get this. They understand that everything's connected, that when we flush something down the toilet or wash it down the sink, that it goes out to the sea. They understand that. And so it's just really pulling that back and reminding ourselves that everything we do has consequences, that things don't just magically disappear and we never see them again. And so this was some work that Barry Peake, who was in chemistry, and our PhD student Alfred did over a couple of years. And Alfred had the joyous job of going out to the sewage treatment plant and getting some of the wastewater out there to start seeing what was coming out in our water. And again, really low levels, but we are seeing pharmaceuticals coming out even through our wastewater systems here because the systems aren't just set up for that. It's quite interesting. I really didn't want, today I wanted to talk about the research. I didn't want to talk about the metrics, but I did have a quick look today, as you're killing time before this lecture, at some of the metrics of this work. And one of the papers we published was in a journal with an impact factor about 7.5. It's been cited 250 times. And so this is, as well as being important, and for all of those reasons, it actually has metrics, because when you're working in a space that thinks about the bigger picture, people are interested. And so, as well as doing the right thing, because we should do the right thing from the academic, from that metric space, it's really important too. I do want to give a shout out to one of my friends and colleagues, Sandy Bowen, and she's working at Pharmac at the moment in the access and equity space. And we mentioned before that financial cost is not the only barrier to access. And one of the reasons is that to obtain a prescription, you need to go and see a doctor. And that means that there's a part charge, that means you need to make a schedule, that there's a whole lot of system barriers around there that make it really challenging. One of the projects we'll talk about in a minute is that a lot of people don't want to make appointment times, or appointment times aren't when they want them, they're delayed. And so a way of thinking about how we increase access is what is best for the patient. So where can they access the care they need at the right time that is maybe not in the system, that the way that we think about it through this doctor one. And so I'll bring you on to one of my great friends. So on the left-hand side there's Dr. Natalie Gould, and she's internationally recognised for what was for reclassification. The lovely lady beside her is Alison Van Beek. Did I get that right, Anita? Van Beek, who works at Green Cross Health. And Green Cross Health has pharmacies and medical centres, and they look after, the idea is to advance clinical care. So they won several awards for this work, which was reclassifying trimethoprim to a pharmacist-only medicine. Now this is for acute urinary tract infections, uncomplicated, and the beauty of this whole process was it put the patient first. And it said that actually when a female patient, because we actually excluded men, they were a referral path, a female patient comes in with an acute UTI, they actually don't want to wait 2 or 3 days for an appointment. They want to pop in at their lunchtime, they want to talk to someone, they want to see if they need to go and see a doctor. And the beauty of this one is that trimethoprim, if you understand the drug, it's a very simple dosing. It's 1 dose for 3 nights consecutively. Nice simple dosing regime. And what was interesting about this idea of changing that narrative is that the work that Natalie and I did following this up, patients loved it. Patients loved it. Many GPs, not all, didn't love it. And again, it's about changing that narrative. So there is a role in all of these conversations for the medical doctors in here. And when this reclassification went through, it was with some really clear parameters that actually there were certain ages, so we don't go over, I think it's 65, that if there's any consideration that it could be some kidney infection, it's straight referral. So it's really quite tight parameters. And I think when the medical team realised that actually this was full clinical consult with those defined parameters, and that it meant the patients got access when they needed it, there was quite a shift in that. What's been really cool though is that, and this is about some of the outreach about why you do cool stuff with cool people, is that currently we're working with QUT over in Queensland, and Queensland Health want to implement this. They were hoping to implement it on National Women's Day, which was mid-COVID, but so we're working with them to have this as a pathway for their female patients. This one possibly a little bit more controversial and exciting. And again, Natalie and I worked on this one with Douglas Pharmaceuticals. And the idea was that could we make sildenafil a pharmacist-only medicine? And everyone goes, why would I want to do that? One of the problems we were finding is that many of our male patients didn't want to make an appointment. They didn't want to have to schedule it, and it was a very last minute. We'll go in for an ear infection, and as we're walking out the door, we'll have these conversations. The reason this one was reclassified, and quite successfully reclassified, was because of the opportunity here. So erectile dysfunction can also be an indicator of early cardiovascular disease, small vessel occlusion. And so when this went through the reclassification process, the number one parameter that pharmacy had to do was a cardiovascular risk assessment. So we've got a population of men who aren't going to the GPs anyway, that come into the pharmacy, and we perform a full cardiovascular risk assessment and with referral, and again, I'll show you the form's incredibly precise. And it's one of those situations where literally if someone's walking past the pharmacy, oh, I'm going to have that conversation now, they pop in, and then they can actually have a clinical consult and be referred to or through as necessary. I know this slide's terribly hard to read, but what I wanted you to understand is that this is quite a rigid process that we go through about what, exclusion, shush Anita, exclusion criteria. We constrain the age bands. We do a whole lot of things to make sure that what we're doing is safe for the patients. What was interesting in this graph that I've got on the left-hand side, which Natalie sent through to me, this image is the counterfeit drugs or coming through the border. And so what we see, the blue line is sildenafil and the red line's a similar product, sildenafil. So we did the reclassification in 2014, and what we can see is the number of packets that were confiscated in the border, sort of about 4,000, I think, in the year of 2014. But once we did the reclassification, that number dropped, and that number dropped because people were coming into the pharmacy and had a different legitimate source. So it's quite interesting, and it made it quite a normalisation process. One of the things, and I know there's several GPs in the audience, that's really important to me is the idea that this is not competition, this is about collaboration, and it's providing multiple points for a patient to come into the system. And in the reclassifications that we've worked on, a couple of the ones that are coming online soon, it's about giving people opportunities or options, creating multiple entry points into the pathway. But we do want to work as a team, and the idea about having shared records and those sort of things are really important, because we end up in a situation where one person has some information and someone has other information. It's actually not in the patient's best interest. So thinking about those wraparound, thinking about those shared records is really, it's not easy, but it's really important. And again, this mantra that came through, which is about for the patient, it's better, sooner, more convenient. Trying to think about ways that we can make it easier for patients, excuse me. This lovely lady is Patty Napier, Dr. Patty Napier now. And again, the journey, Patty taught me when I was a pharmacy student, and then several years later, Patty came and did a PhD with me. The cool thing about what Patty and I did was around, can we change the way that we distribute our workflow? And one of the things that's really important for pharmacists is that we end up unintentionally, we have good intentions of being out with our patients, but we end up at the dispensary. And there's a bit of a rhetoric around the fact that we're tied to the dispensary. It's really hard to walk away and have those conversations. And so what we did was we took a model which is implemented in the UK, what's called a checking technician. And we thought, how do we make this happen in New Zealand? And the idea is that when a prescription comes in, the pharmacist does the clinical assessment, they're looking to make sure it's appropriate, the doses look fine, they look at the patient record. But once we get to this part here, this technical, mechanical part of, is that 10 milligrams, is that 10 milligrams, is that, that doesn't need the same level of clinical expertise. So could we take what is effectively a production line and slice it into chunks, where we had the best person doing that part of the task, of the workflow. And so we ended up, actually we got some money eventually from Health Workforce New Zealand to run a pilot. And it became quite clear quite quickly that this was actually almost, I want to say a no-brainer, nothing's a no-brainer, but that the ability to allow pharmacists to focus on the cognitive aspect, the clinical aspect, and then to allow other people that have got much better attention to detail to perform those tasks, actually increase safety. And there's a recent meta-analysis that's come out in the countries that have got this, and they show there's actually less dispensing errors because you've got the right people doing the right part of the process. Again, we had to really socialise this because a lot of pharmacists don't like letting go, maybe is the best way to say it. the pharmacists wanted to own the whole process, and they want to be everywhere, and who's going to be responsible, and because we're very responsible people. And so it's just about reshifting the way that we have this process. And again, as I said, we were lucky, so we ran a nationwide pilot, and it's being implemented now. I've made it sound really easy, but these things never are, because there's law, there's service specifications, there's 101 hurdles. But this is a really cool opportunity for taking pharmacy support staff and giving them a pathway for success too, and allowing them to flourish while pharmacy are moving into a certain space. I want to finish the talk about the research aspect, about where to next, and I think at least one or two of these people in the audience. This is one of the beauties of working at this university, is that there are a lot of bright people who want to do really cool research for their patients, and so I've been fortunate enough to work with all of these clinicians. So some of you all know there's Associate Professor Michael Tatley, we've got Dr. Sharon Patterson, Dr. Helen Patterson, not related, and Professor Michael Schultz over there. Oh, I've put him over the words. Because it doesn't matter what clinical area you're in, the way that we use medicines, the way that we have access to medicines, what patients do with their medicines, if they don't get better because they're not taking their medicines, these are ubiquitous across all of these clinical areas. And this has been one of the true joys for me, has been working with other clinicians who really want to do the right thing for their patients. And these are people, look, Michael's here, the work in the pharmacovigilance space, Sharon, who goes on these amazing walks to raise money for her cause. We've got Helen, who has this reproductive health bus that she's set up, and Michael Schultz, I was thinking about him, and I currently sit on Pharmac's PTAC committee, so I see the letters that Michael and his clinician friends write to the Pharmac saying, funded these for my patients. So it's really nice to work with people that really want the best thing for their patients. This photo was taken in 2012. Some of you may recognise the person in the... John Key wasn't available when I got the Prime Minister's Award that night, so... and this was a really special moment. Really was, because we're an incredibly research-intensive university, and that's something that is really important and that I really love. Sometimes teaching feels like sort of the poor cousin, and I don't think it needs to be that way. I think that actually they both can feed into each other and create much bigger opportunities and much better outcomes for everyone. So I think research, I've said here, needs to have an impact, and some of the research we do can take a long time for impact, but if we can encourage our students to think about what they're doing, why they're doing it, how they can move things in a particular direction, really important stuff, and I think it has much further reaching implications sometimes than we realise. Those opportunities to challenge and critique and reflect about why they're doing something, could it be done better, those are actually really important aspects. And so that's really my point that I really wanted to make on this, is that the idea to link the two. We talk about it and it's not always easy, but it's really important and really needs to be acknowledged. I put this one in, and I'm being a little bit cheeky because we talk about these service roles, and sometimes service sounds like it's a penance. And I almost wanted to change the narrative and say that it's actually strengthening. These are opportunities that we have. And we're in a fortunate position, and I don't mean just because I've got my red gown on. I'm in a fortunate position because I can take the knowledge that I have and I can use that and I can inspire others and I can make a difference to those people that haven't come through the same pathways as me. And I think that's the point that I wanted to hear, is that this gift of knowledge and influence should be shared. And these are about strengthening the bonds between the university and the community, strengthening the expertise that's available to these groups, and understanding research and teaching. And these are just some of the organisations that I've provided time and energy, and my family will tell you nights away in Wellington, there's always these Wellington meetings. And it's because it's important, and I think that these are the things that we can do that are actually really outside ourselves, and I'm just being cheeky and calling it strengthening rather than service, because I think it strengthens both ways. There's a few people that I specifically want to acknowledge. The university in its entirety is something that's really important to me, and it was mentioned before. I mean, the university is part of my life now. What do we work out? 25 years. I came here and did the health science route, fell in love with biochemistry. And then, of course, from there fell in love with pharmacy. And at the time I did pharmacy, this was the only university. And so I've been very proud to be part of this university. Oh, my spacing's kind of been messed up, but that's all right. One person I really wanted to acknowledge was Ian Tucker, Professor Ian Tucker, and he was the person that when I was finishing off my PhD said to me, "We've got an academic role, would you apply for it?" And I think that ability, that support, the opportunities that have come from being part of this university are quite phenomenal. There's two people on here, and I'm sorry that the formatting's changed. To Associate Professor Michael Tatley. He's been just a delight, and to Associate Professor Patricia Priest, the time that I've spent under Prev Med, and the culture and the real vibrancy of these units is something that I'm really cherish. Put a shout out there to the Pharmaceutical Society of New Zealand. Possibly a bit loaded. I'm currently the vice president of the society, but well before that, the reason I am the vice president is because it's an organisation that I really believe in, and they've done a lot of the work and support around these advancing pharmacy, thinking about new opportunities, providing training and support, and trying to get pharmacy positioned so that they're not seen as the poor cousin, and that they actually are a legitimate health professional that can provide really good access and good clinical support to the whole healthcare team. And again, a real shout out to all the collaborators, contributors and students. I am going to go quickly down to the personal sort of spot. There's one person that who can't be here, that I really want to acknowledge, and that's my dad. So my dad passed away 2013, it must be. So the reason it's important for me to acknowledge my dad is that my dad was a professional soccer player in England, and he came out to New Zealand on a contract with Dunedin City Football Club, and he met my mum and stayed. So my dad, for all his was he cursed? He had 3 daughters, and so so this professional athlete and his 3 girls. And the thing that I remember the most about my dad is that he told us we could do anything, we could be anything, and he really genuinely believed that there was nothing that the world couldn't offer, and that the opportunities were always there. So I'm the first in my family that came to university, and I really put a lot of that down to my dad. And Mum, I love you, but there was something that there was something about this unwavering belief that his girls could take on the world. It didn't matter. And so, there's, he's very, obviously, my dad is very special. One of the things that happened to my dad in 2011, 2012, he had a quad bypass and he stroked on the table. And I remember the first time he left the house was, it must have been early, and so 2012 was when I received the Prime Minister's Award. And I remember the first time he left the house was to come and meet the Vice-Chancellor, and about how special that was. So these are things that really make people who they are and really drive us forwards. So he's a big, inspiration. And again, these things wouldn't possibly be possible without those wonderful people who have shared this journey with me. And there's many faces up there that you'll recognise. Some of them have been overtly instrumental, some more covertly instrumental. And I think that's, again, one of the joys of being an academic, is that there are a lot of people who have got a lot of great ideas and want to make a difference to their little corner of the world. And so I'm incredibly grateful, and really think that's about where... Tell my family I wouldn't acknowledge them. Oh, I'm sorry, Ashley. I've been incredibly blessed. I have the most fabulous family. My husband, who is my best friend, and again, another person who believes that you can be anything you want to be. Just go for it. So, thank you, family. Thank you, and thank you for everyone that's taken the time to come tonight. And I'll leave it there on that note.
truly delighted that I have attended this lecture. Congratulations, Rhiannon. What she taught is outstanding. If I can summarize in few words, she taught us about New Zealand medication classification. She taught us how lucky we are in New Zealand to have fully funded medications that co-pays $5 capped at $100 per family. It's incredible, incredible. I left New Zealand 15 years ago to the United States and returned this year, and I know how lucky we are. Then she went on to teach us sometimes that privilege and luckiness can lead to waste, and how human behavior leads to that waste. Finally, I was really attracted by this concept of reclassifying drugs in a controlled and systematic manner if you deploy it at a point of care in pharmacies, how valuable that is for primary care and patient care. I just want to finish a quote that I took out of her lecture. Do the right thing and measure the right metrics. And we want to thank Rhiannon, the families, for your contributions. All of you attending this lecture. And on behalf of the University of Otago and Otago Medical School and the Department of Preventive and Social Medicine, I wanted to give her a small gift.
Kia ora, tēnā tātou koutou. My name is Paul Brunton and I have the privilege to be the Pro-Vice-Chancellor for Health Sciences. And I have two duties tonight. And the first one is to thank you, the audience, for attending this evening. These are important academic events within the university. And as the Vice-Chancellor has already mentioned, we're enjoying freedoms that are not being enjoyed elsewhere in the world that allow us to come together tonight. And I think this is the first post-lockdown IPL, second, sorry. So we should recognise that. So thank you for joining us this evening. You're very welcome. And my final duty is to invite you to join us for some light refreshments in the staff club. And if you follow the walking bus, you'll find the destination. And please continue the conversations and fellowship. Thank you very much indeed.